Hello, good afternoon, everyone. We would like to welcome you to the 275th webinar of health updates here on TVUP. And we're going to answer the question, rare disease, safe ba ang anak ko? We are going to talk about some of these rare diseases. Well, they call them rare diseases, but actually about 300 million people in the world are affected by rare diseases. And the issue is that most of these, about 70%, are children. And many parents don't realize, and many doctors and nurses are not able to diagnose. So it takes 5 to 7 years before the diagnosis is properly made. So there is a lot of suffering that goes on for the individual as well as the family because they don't know what they are dealing with. So we're going to talk about three types of diseases that are found in the Philippines: maple syrup urine disease, Pompe, and Osteogenesis Imperfecta. You may have heard of these diseases. We have an expert who will talk to us about what they are, how common they are, what are the signs and symptoms. And we do have a very special guest, a patient who will also be talking about his struggle with Pompe's disease. So I'm Susie Pineda Mercado. I'm very happy to welcome all of you. I see a lot of familiar names on our chat box. I encourage you to put your questions and other comments that you have on the Q&A and on the chat. And I am delighted to co-host this webinar with a very good friend, Dr. Stella Legaspi Jose. Stella, welcome to the webinar.
Good afternoon, everyone. Good afternoon, Susie. And hello to all our participants here in the live broadcast of the Zoom webinar and all those watching via live streaming on TVUP YouTube channel, as well as the UP System Facebook page, the TVUP Facebook page, and of course, from TVUP. At Health Updates, we bring to you the latest information on health and medicine. Today, we are joined by Dr. Ebner Bon Maceda, who will answer the question, rare disease, safe ba ang anak ko? So let's list back to you, Susie.
Oh, thanks a lot, Stella. So usually we have what we call the patient the person on the street. So we typically interview people about their views on things, but today we've got a very special interview. We have with us on a taped interview a survivor of Pompe's disease, and it's a very, what should I say? It's a very insightful interview, and I hope that this will bring us all a better perspective of rare diseases. So let's watch this from TVUP.
My name is Juan Benedicto Mandarag, and my friends and family call me G-Coy. And currently, I am working with the Asian Development Bank. I've been doing that since maybe 20 years. So yeah, I've been doing this for a fairly long time. So I have a rare disease called Pompe's disease. It's a rare neuromuscular disorder and a metabolic disorder. So I lack when my body produces very little uh, acid alpha-glucosidase. Continuously, I had the first symptoms at the age of 10. So before the age of 10, I was a normal child. I could run, I could jump, I could swim, I could do almost all the things that normal kids could do, and then slowly I lost the abilities to run, to walk. Then years after, I started to have difficulty breathing, and then now I have to rely on a breathing machine to help me breathe. It's a very rare disease. affecting 1 out of 20,000 accurately diagnosed in the United States. But in the Philippines, they thought I had muscular dystrophy. So, but then we went to see, we had a chance to go see a specialist in the US for muscular dystrophy. We did a muscle biopsy, and the muscle biopsy confirmed it wasn't uh, muscular dystrophy, and it was indeed Pompe's disease. So the first symptoms surfaced when I was 10 years old. In my case, the the change in physical capabilities was over a long period of time, from being able to breathe on my own to becoming totally dependent on a machine was another 10 to 15 years. So I've had a lot of time to accept my disease. I've had a lot of time to adjust. And that helped me a lot. The second thing was perspective, meaning I was very fortunate that I grew up with a good role model, which was my dad, who was a very positive person. Instead of uh, feeling sorry for myself because I can't walk, or I can't move, uh, I focus on the blessings that I have, which is having the opportunity to finish college, being able to work, having gainful employment, being grateful that I was born into a family that had some means, some means to help me. So I think those are the major things that have really made a huge difference in my life. To the doctors, be diligent, be thorough in looking after your patient. Don't just fit a diagnosis based on something that is, let's say, 90% you think is right. If they said I would have never lived past the age of 30, I'm already 48, so that is almost 18 years of bonus time when they thought that was the life expectancy. So you never really know what life will bring you. So try to live your life as best as you can so that no matter what happens, you've at least made the most out of your years here in the world. So don't be afraid to go out of your comfort zone and try to do as much as you can.
Yes, thank you so much, TVUP, for that clipping. You know, in the interview, Stella, with Dikoy Magdaraog, uh, one would really feel the, what should I say, his sense of purpose, and such an inspiration, I think, for everybody. So that was Dikoy Magdaraog, and I think he has been through many interviews, and we're very grateful, if you're watching, Dikoy, that you give us some time to share your story with us. So Stel, we are going to talk about certificates of attendance. Those should be given to those who have watched at least 50% of the webinar duration. And if you have any questions, of course, you can just put it in the chat box or inform us here at TVUP. So over to you, Stel, to introduce our expert speaker.
Our expert speaker is, wait a minute, is Dr. Ebner Bon Maceda. He is the director of the Institute of Human Genetics at the National Institutes of Health in the University of the Philippines, Manila, and the Philippine General Hospital.
Okay, welcome, Bon. And for our audience, just to let you know, no, na hindi naman nahuhuli ang Pilipinas, no? The Philippines is moving ahead really well in this field. And Bon is with the NIH of UP Manila, and I know we'll share a lot. So Bon, welcome to the webinar. Please take the floor.
Thank you very much, Doc Susie, Doc Stella, for the introduction. And I'm glad to be here with you to share some information on rare disease. So actually, we are celebrating the Rare Disease Week this last week of February. And we will be talking about three conditions, mainly maple syrup urine disease, Pompe disease, and osteogenesis imperfecta. So I have no relevant disclosures, and the objectives of this talk is to give you an idea on what rare diseases are, describe the global and Philippine impact, provide an overview of the pathophysiology and management of these three conditions, discuss the challenges faced by individuals and their families, and to emphasize the importance of early diagnosis, equitable access to care, and the development of stronger health policies and support systems for rare disease patients. So do you know that the zebra is the symbol or the mascot for rare diseases? No? So it comes from the medical saying, when you hear hoofbeats, think horses and not zebras. So in this medical saying, the zebra represents uncommon diagnosis, conditions overlooked or misdiagnosed, and the need for clinicians to think beyond the usual. And like human fingerprints, no two zebras have the same stripe pattern. And this uniqueness mirrors the rarity and complexity of rare diseases. The WHO describes rare disease as a condition which is often described as a specific health condition affecting fewer than 1 in 2,000 individuals in the general population. So as you can see, the WHO already recognized that there are actually different definitions of rare diseases. So there is no standard definition of rare disease, but this is the more commonly described definition. In a study by Richter, they try to standardize the definition of rare disease and for per 100,000 people. And you can see here for Korea, for example, it will be around 5 per 100,000 people, or that is 1 in 20,000, up to around 76 in China per 100,000 people, with a global average of around 40. So there's no single correct definition of a rare disease, and it is since rare disease isn't just a medical idea, no? It's a political, economic, and social one. So different countries design the definition to fit their own system and priorities, and countries are answering different questions. How do we fund care? How do we stimulate drug development? How do we plan services, and who needs protection in our system? In the Philippines, our definition is 1 case per 20,000 people. And all over the world, there are around 7,000 rare diseases. No? So this number is based on databases like Orphanet and clinical registries that track distinct conditions commonly classified as rare. Because these definitions and data sources differ, some analyses count more specific entries, including genetic variants and very narrowly defined phenotypes or presentations. So using this broader approach, there actually may be more than 10,000 rare diseases globally, and new rare diseases are discovered every year. Actually, when we all combine all people, if all people are with a rare disease live in the same country, it will be the third most populous country next to India and China. It affects around approximately 3.5 to 5.9% of the worldwide population. And when extrapolated from the 2025 population, which is around 8.23 billion, that is equivalent to around 288 to 486 million people affected with the rare disease. Patients with so these are the characteristics of rare diseases. No, 75% of rare diseases affect children, as mentioned by Doc Susie earlier. 70% of genetic rare diseases have their onset during childhood. 72% of rare diseases are genetic, although there are other rare diseases, no? So, which may be due to infections, allergies, or other environmental causes. Actually, there are also rare cancers. So, all of these are considered rare diseases, no? They are often chronic, progressive, and life-threatening. And the diagnosis and treatment are very rare for such diseases. And actually, only around 5% have treatment. So the treatment, we call these orphan drugs or orphan products. So orphan drug is defined as one intended for the treatment, prevention, or diagnosis of a rare disease or condition. So because of this, rare diseases are also known as orphan disorders because they are orphaned in terms of treatment. It's not a focus of pharmaceutical companies due to small market demand and expensive R&D. And also, they are orphaned by society. They suffer from social abandonment because of the lack of existing network of support. So these are just examples of rare diseases, no, from our data here in the Philippines via the newborn screening program. So you will see majority, not all of the conditions are rare, but majority of the conditions being screened by the newborn screening program are considered rare, except for congenital hypothyroidism with a prevalence of around 1 in 2,560. But the rest of these conditions, you will see that they fit the definition of 1 in 20,000. So another condition which is not considered a rare disease, screened via the NPS, is the G6PD deficiency, and maybe specifically alpha-thalassemia, the hemoglobin H disease, with a prevalence of 1 in 2,427. But the rest of the conditions, they fit the definition of 1 in 20,000. One of these conditions that we screen via the newborn screening program is the maple syrup urine disease. So this is a metabolic condition wherein there is a lack or deficiency of the branched chain alpha-keto acid dehydrogenase enzyme. This enzyme is very important in the breakdown of branched chain amino acids, leucine, isoleucine, and valine. And because of the block in the metabolism, there is the manifestation of the signs and symptoms of MSUD, one of which is the sweet-smelling urine. And also, early detection via the newborn screening can prevent brain damage. And patients with MSUD may present with convulsions and developmental delay and even death if not detected early. Um, the worldwide prevalence of MSUD is around 1 in 185,000 live births. But in our data, we saw that it is a little bit more common, although it still fits the definition of 1 in 20,000. No? So in 2021, the data is around 1 in 66,000. So that is a little bit more common compared to the world prevalence. For certain populations, it's more common, specifically for Ashkenazi Jews, 1 per 26,000 live births, and in Mennonites, 1 case per 176 newborns. So because of the block in the metabolic pathway, the substrate increase. So that includes increase in the branched chain amino acids and the branched chain keto acids. And of these three amino acids, leucine is actually neurotoxic. And isoleucine is converted to sotalone, which causes the sweet smell. So in our patients with MSUD or maple syrup urine disease, at the first 24 hours, they may present with already the maple syrup odor in cerumen and other bodily fluids. No? And if we check for the plasma, branched chain amino acids may be elevated. By the 24th to the 72nd hour of life, they may present with irritability and poor feeding. And these manifestations may be misdiagnosed as sepsis neonatorum. No? But when we check for the branched chain keto acids, they may also be elevated. By the 48th to the 72nd hour of life, they may present with maple syrup odor in urine. But if you are not trained to, if you are not familiar with the condition, you don't know the smell, this may become or may be misdiagnosed as something else, no? Specifically sepsis. By the fourth to the fifth day, they may present with deepening encephalopathy, lethargy, intermittent apnea, opisthotonus, and stereotypic movements. And by the seventh to the 10th, they may succumb to death. In our newborn screening program, we screen for our patients immediately after 24 hours, 24th hour of life, with the goal of diagnosing these patients early and being able to manage and avoid the complications or the sequelae of maple syrup urine disease. So these are just some photos of our babies with maple syrup urine disease showing opistotonic positioning, hypotonia, and even hypertonia. The clinical presentation of MSUD is actually broad, but what we've discussed earlier is the classic type. And this is because the enzyme activity is almost absent. No? So that's around 0 to 2%. So they present earlier. No? So they present during the neonatal period, and these are some of the clinical and biochemical signs. However, we also have intermediate types of MSUD. The enzyme activity is around 3 to 30%. They may not be as toxic as that of the classic type. However, they may present with developmental delay later on. We also have the intermittent type of MSUD. So these patients, they are normal. No, the branched chain amino acids when well is normal. They have normal growth and development, but when they have an illness, like for example, infection, pneumonia, they may decompensate. No? They can have metabolic crisis, and the presentation is similar to that of classic type. Another type is thiamine responsive MSUD. So for this type, it's the presentation is similar to the intermediate phenotype, but they are responsive to the cofactor. So we supplement with thiamine. So the enzyme activity is around 2 to 40%. Via the newborn screening, we detect MSUD using these biomarkers. So we check for the leucine, and actually this is also being monitored during long-term management. But for confirmation, we do plasma amino acids. Specifically, we look into the different branched chain amino acids. In addition, the alloisoleucine, which is an amino acid not usually elevated, but in the presence of a blockage, like in MSUD, alloisoleucine is detected in greater amounts. In addition to plasma amino acid, we can do urine organic acids, and these two tests are available only in NIH. So we have the biochemical genetics laboratory. The third confirmatory test is the branched chain keto acid dehydrogenase enzyme activity. So this is not usually done, and it's not available in the Philippines. We rarely do it because of degradation issues and other sample-related concerns. But what we can do, if there is an equivocal case of MSUD, we can do molecular testing. However, this is also sent out. So during the neonatal period, upon diagnosis, and even in cases of when patients with MSUD present with infection, an acute metabolic crisis may occur. And during this time, the goal of the management is actually to have a balance of the protein breakdown and protein synthesis. So what we do for patients with MSUD is we control the protein intake. For the first 24 hours, we remove the protein intake. We increase the calories. because during illness, no, our patients with MSUD, there's an increased demand for energy, the stores are being used up, and there is degradation of protein, which causes elevation of the amino acids, including the branched chain amino acids. And because there is elevation of leucine, which is neurotoxic, the manifestations of MSUD may occur during this time. So in addition to protein restriction, high caloric supplementation, we correct the metabolic abnormalities. We eliminate the toxic metabolites, specifically leucine. In cases of severe elevation of leucine and the neurologic manifestations, specifically when the babies present with increased sleeping time, we can do dialysis for our patients with MSUD during this acute metabolic crisis. We treat precipitating factors, specifically if there is an infection, and we provide cofactor supplementation like thiamine. And to prevent associated sequelae, so patients with MSUD may even present with seizures. However, the long-term management for MSUD is primarily dietary. So we restrict leucine or the protein in general. We provide high-caloric branched chain amino acid-free sick day formula. So they have that so-called sick regimen, and they have the special milk devoid of the plasma of the 3 branched chain amino acids. And there's frequent outpatient monitoring. So although it is primarily dietary, the management is really dependent on also on the compliance or the adherence of the patients, and also the regular monitoring, because the weight of the diet is also dependent on the weight of the patient. So we've talked about MSUD, and that is screened via our newborn screening program. But another condition, as we have seen in the video earlier, is Pompe disease. Unfortunately, this condition is not screened via our newborn screening program. There are some countries, specifically Taiwan, who screens for Pompe disease. But in our country, this is not yet included in our panel. So this condition is also a metabolic disorder. Specifically, it is a glycogen storage disorder. And like MSUD, it is an autosomal recessive condition, meaning for a condition to occur, the 2 copies of the gene must be affected or have the pathogenic mutation, meaning both parents are carriers. Hence, there is a 25% chance of this condition to occur in subsequent pregnancies in a couple who are both carriers. So this is due to a total or partial deficiency of the acid alpha-glucosidase enzyme that hydrolyzes the lysosomal glycogen. So the lysosomal glycogen then accumulates in tissues, resulting in progressive debilitation, organ failure, and death. So in this figure, you will see, diagram above, no, on the left, shows a healthy muscle fiber. Alongside this figure is an affected muscle fiber. So in Pompe disease, the glycogen accumulates in the lysosomes. They swell and push the myofibrils to the periphery. So glycogen also seeps out of the cell into the extracellular space. And this actually impairs muscle function. It causes wasting and damage, affecting the skeletal, smooth, and cardiac muscles. So that is why Pompe disease, as you have noticed earlier, it affects mainly the muscles. We have 2 types, the infantile-onset Pompe disease and the late-onset Pompe disease. The difference is the timing specifically. So they usually, the infantile onset in the first year of life. After the first year of life, that is late-onset Pompe disease. In addition, the presence of cardiomyopathy in infantile onset. So for the late onset Pompe disease, it usually affects the skeletal muscles, no, and the respiratory muscles. So these slide just shows the signs and symptoms of infantile onset Pompe disease. And as you can see, for Pompe disease, there's normal cognition. No? So although the manifestations, the cardiac manifestations, that is the main problem mainly in Pompe disease, no, the affectation of the heart, no, so there's cardiomegaly, hypertrophy, no, so but there's also muscle weakness similar to that in late onset Pompe disease. So in onset Pompe disease, so they can occur anytime after 1 year old, no, so they can, as in our patient, he presented at 10 years old, but patients with late onset Pompe disease can present even on the third, fourth, or even the fifth decade of life. So they have progressive muscle weakness, no? So eventually affecting also the respiratory muscles, and they are prone to infections later on. The confirmatory testing of these condition is via biochemical or enzymatic diagnosis or molecular diagnosis. So just like in MSUD, there is also enzyme analysis. Again, this is not available here in the Philippines, so we send this out if a patient is suspected to have Pompe disease. In addition to, so as you have seen here, if the enzyme activity is less than 1%, so that is probably infantile onset, 2 to 40% enzyme activity for partial deficiency or the late onset. In addition to these biochemical or enzymatic diagnosis, we also do molecular diagnosis. So currently in the Philippines, we have a number of patients, maybe less than 10 or less than 5 patients with Pompe disease. And as mentioned earlier, the prevalence of Pompe disease still fits the definition, 1 in 20,000. So in literature, you will see that the prevalence is around 1 in 18 to 40,000 patients. The management of this condition so is enzyme replacement therapy. It's different from the condition that we mentioned earlier that is primarily affected by diet. For this condition, it is not affected by diet. And what we need to do to avoid the progression of the disease is to provide the enzyme which is deficient in the patient. So there's enzyme replacement therapy. So again, this is not available in our country. We apply our patients with Pompe disease abroad for um, under the charity program of the different suppliers of the enzyme. So it is dependent on the approval for the medication. So this medication per vial, the vial for enzyme replacement therapy is around 50 milligrams, and that costs around 70 to 80,000 pesos. And as you can see, the dosage is around 20 milligram per kilogram every other week. So it is a very costly medication. In addition to enzyme replacement therapy, specifically if there are patients who will not be receiving or who are not able to receive this enzyme replacement therapy, we do surveillance, no, and monitoring of the different parts of the body. No? So we have a regular evaluation. So upon diagnosis, these are some of the evaluations for Pompe disease. So we have respiratory, hearing, cardiac, gastrointestinal, neurologic, musculoskeletal evaluations. So in the treatment, no, in addition to enzyme replacement therapy, is supportive. So it will depend on what specific manifestation that is present in a patient. No? So there can be some of these concerns, so cardiomyopathy, conduction disturbances, scoliosis, osteoporosis. Of course, there can be also later on communication difficulties, respiratory insufficiency. So these are some of the concerns, no? So some or many of our patients, especially in the latter decades, they may be needing respiratory support, including BiPAP. So as you have noticed, no, although the so MSUD screened by our program, newborn screening program, Pompe disease, you have noticed the difficulty also, no, because it presents similarly to other neuromuscular conditions and diagnosis may be delayed. Another condition is osteogenesis imperfecta. So this is also known as the brittle bone disease. So it's a collective term for a heterogeneous group of connective tissue syndromes characterized primarily by liability to fractures throughout life. So the prevalence is around 1 in 10 to 20,000, and the vast majority of patients with osteogenesis imperfecta is due to the mutation in COL1A1 or COL1A2, primarily important in the production of type 1 collagen, which is important in bone development. But in recent decades, no, so in recent years, we have seen that there are more genes involved in bone development, and mutations in these genes may cause frequent fractures, no, and may cause osteogenesis imperfecta. And previously, what we usually, where a majority of the conditions are actually due to COL1A1 or COL1A2. But you will see here that there are also other types of osteogenesis imperfecta which are inherited via autosomal recessive manner and even X-linked. So there lies the importance of genetic testing in some cases. The general features of osteogenesis imperfecta include fractures with minimal or no trauma. So actually, this is one consideration in cases of child maltreatment or abuse. So this is also considered in the presence of other features, which include short stature, bone deformity, the presence of blue sclerae. So there are types of osteogenesis imperfecta which will present with blue sclerae. Dentinogenesis imperfecta, or the translucency of the teeth, is present in some cases or in some types of osteogenesis imperfecta. Hearing loss, because as you know, the smallest bones are in the ear. Joint hypermobility and cardiovascular complications. So just to show you the different types based on severity, so you have seen earlier the types based on the gene involved. Now we can actually also look into the types based on severity. And the type 1 is actually the mild type. No, it's a non-deforming OI with blue sclerae. So these patients, they have the annualized fracture rate less than 1 or equal to 1. So they are ambulatory and they are usually short. So this is the type of osteogenesis imperfecta where we see affected individuals in multiple generation, because there is usually no that great disability noted in this type of OI. So type 2 is the perinatally lethal type, no? So they may have respiratory distress leading to perinatal death, and some of these patients have fractures even during pregnancy. Type 3 is the progressively deforming type of OI. So they usually have greater than 3 fractures per year. And you will see that the bones are severely deformed. They may not be, many of the patients are not ambulatory, and they have regular fractures, no, more fractures compared to the type 1. Type 4 is between type 3 and type 1. No? So it's not as severe as type 3, but it's not as mild as type 1. Type 5 is a special type of OI because they have interosseous calcifications. No? So there may be restrictions in pronation and supination in the presence of these calcifications. Via X-rays, no? So in addition to the physical examination, actually this type of rare disease can be diagnosed via the X-ray. So there is osteopenia, the cortical bone thinning, the bone fractures, and the bone deformities which are seen. So in some cases, molecular testing may be needed, but for this type of condition, we may or may not do depending on the case. The management of osteogenesis imperfecta is multidisciplinary, and it is focused on increasing bone strength, maximizing mobility and minimizing fractures or deformities. And the key approach include bisphosphonates to increase bone density. So there's also surgery via intramedullary rodding for deformity correction and physical therapy and braces. Specifically for bisphosphonates, so the usually given medications are pamidronate and zoledronic acid. So the problem, however, is currently, so as you can see, pamidronate is often used in children. And for older children, we give zoledronic acid. Zoledronic acid is available or is in our formulary, but pamidronate, we usually get this by donation from abroad. So which is mainly required for newly diagnosed or the smaller children. So initially we start with pamidronate. Then later on we can shift to zoledronic acid. So as you can see, this is one challenge also, the availability of the medication. In addition to bisphosphonates, we give calcium and vitamin D supplementation. There are emerging therapies, but currently we usually just give bisphosphonates and supplementation. So this is the medical treatment, but we also have surgical management, which will include intramedullary rodding. So now there are cases which uses telescopic rods, so that it can prevent frequent surgeries, because as you know, as the child grows, so um, the bones also grow, and these rods, the telescopic rods, will grow with the child and avoid the frequent surgeries. In addition to intramedullary rodding, there can be spinal surgery for scoliosis or vertebral deformities, and fracture fixation, minimally invasive or external fixation when necessary. So in addition to the medical and surgical, we also have the therapy, the rehabilitation, physical, occupational therapy, the nutritional support, and genetic counseling. So there's also surveillance. No, actually, what we do for our patients with osteogenesis imperfecta, we hold regular multidisciplinary clinics. Just like for patients with MSUD also, we do multidisciplinary clinics. It's a one-stop shop for our patients so that they will be able to see the doctors, the different subspecialties in just one go. So those are the three conditions that we have discussed. Those are the three rare diseases. And as you have noticed, there are challenges faced by our families with living with patients living with a rare disease. No, there can be diagnostic delays, limited treatment, and if the treatment is available, it's of high cost. There's social isolation, and there's emotional strain. So this is actually also mentioned by Doc Susie earlier regarding the diagnostic odyssey that our patients have to experience. No? So it takes around almost half a decade before a confirmed diagnosis. And this data is actually in Europe. And in the Philippines, this can even be longer in our case. It takes around 8 healthcare professionals before the diagnosis, and 22% of patients with rare disease, and 73% will receive at least one misdiagnosis. Some patients will be diagnosed earlier if they are referred in a center of expertise. So in addition to challenges with the medical management in the diagnosis and treatment, it is really of high impact in the family. So you can see here 7 in 10 patients and carers reduced or stopped professional activity due to their or their family members' rare disease. 2 out of 3 carers spend more than 2 hours a day on disease-related tasks. 8 in 10 patients and carers have difficulties completing daily tasks, and 3 times more people living with a rare disease and carers report being unhappy and depressed than the general population. So it's not only affecting the patients, it is really affecting even their families. And actually, there are also challenges faced by the healthcare providers, no? So because, as you know, no, there's still a lack of rare disease education, a limited number of facilities or health systems specializing in rare disease states, the lack of awareness of symptoms related to rare disease, the lack of clinical trials for many rare diseases, and the shortage of physicians specializing in rare disease states. In the Philippines, what we have for rare disease, no? So we have heard maybe about the Philippine Society for Orphan Disorders. So this is the support group for our families and patients with rare disease, no? So in addition to helping them uh, communicate with other families with a similar condition, that will be very helpful for the families. The organization also can help in looking for funds, for example, for specific management uh, concerns, no, or financial concerns on these parts of diagnosis and even management. So, in celebration of the Rare Disease Week, you may join the Philippine Society for Orphan Disorders in their activities. So there's a lighting ceremony in certain areas in Metro Manila to support rare disease. No? So actually, I'm wearing a ribbon made up of jeans, so pants. So this ribbon is being used now for rare disease in support of the rare disease. So this is actually genes for genes because majority of rare diseases are due to genetic causes. So let's support our families and patients with a rare disease. So we have the RA 10747. We have a law for rare disease, for optimum health outcomes for Filipinos with rare disease. And actually, the goal is to integrate the comprehensive care for our patients with rare disease in our existing healthcare delivery system. So to support the rare disease community, you can join the Philippine Society for Orphan Disorders in the lighting ceremony. You can also post in the social media to support to give your support for our patients with rare disease. You can raise your hands for rare. So rare disease is an urgent public health challenge and no person or family is immune from a rare disease. And no disease is rare when it affects someone you love. So these are my references and thank you very much for listening.
Wow, thank you so much, Dr. Bon Maceda, no, and we are really grateful for the work of the Institute of Human Genetics. You did mention that there's still a lot of testing that needs to be done abroad, but at least, it's comforting to know that when people find cases that are difficult to diagnose, they can actually go to you at the National Institutes for Health and that you continue to advance this in our country. So we're so proud of you and thank you. And that was a wonderful presentation. Stella, we're gonna watch it again, no?
Yes, oo.
Thank
Uh,
you.
Congratulations, Bon, ha. Ang dami niyong ginagawa for our country. Really, we appreciate it. There are some questions in
Go
the
ahead,
chat
Stella. Go
box.
ahead.
Oo.
Sige, go
So,
ahead.
there's a question here. How can we have Pompe disease to be included in the newborn screening? And are there IOPD survivors in the Philippines?
Thank you for that, ma'am, no, that question. Actually, that's also our dream, no. So currently, we are screening for 29 disorders. And of course, when we include a condition in our panel, we have some criteria. So one of those criteria is if we are able to provide the treatment. So currently, maybe we will have long discussions before that will happen. There are other conditions in line being considered now before the inclusion of this condition because currently abroad I only know about one country screening for Pompe disease, and that is Taiwan, and they can provide the treatment. And currently what we can do is if the healthcare provider suspects of Pompe disease, we can, and the testing is still not available in the country. So there are a lot of things to consider before the inclusion of that condition, no, in our newborn screening panel. No? So the capability of the country to diagnose and not send this outside. So maybe those are considerations before we will be including that in our panel. But actually, ma'am, Pompe disease is one of the 10 conditions with now we are since we've been starting conversations with PhilHealth as early as 2012, no, even before the law. But now in the through the RA 10747 and the Integrated Rare Disease Management Program, 10 rare diseases, they are creating PhilHealth packages. And that includes Pompe disease, Osteogenesis Imperfecta, and maple syrup urine disease.
Oh, that's very
And
good.
that's very
Very
good.
good news.
Mm.
Yes.
Yeah, good news, no? Kasi you were just mentioning the cost, no?
Oo.
And in the case of Decoy, our guest patient, he's very fortunate because they had the resources, no? But that's why I'm very grateful for all the work you're doing, Bon, and your team. And I think awareness raising is really important. So for those of you who are listening, no, I think for our doctors, our interns, our residents, our nurses, very important to be aware that not everything is common, right? Sometimes there are conditions that are, cannot be explained and we have to ask for help. We have to ask for help kasi kawawa naman yung mga pamilya. I just remembered Bono. I don't know if you saw. There were two movies on on osteogenesis imperfecta. In the year 2000, Bruce Willis and Samuel Jackson had a movie called The Unbreakable. You should watch it. I mean, if you haven't seen it, no. And then last year another one came out, very touching story about a boy with osteogenesis imperfecta and autism. So it's called The Unbreakable Boy. So I think there's a lot of interest in it, but I think we need to translate that. You mentioned this earlier. We need to translate it into systems, into services, so that it's not just something unusual and nice to talk about, but that we can really help these families. No. So I have a question for you. Stel, I think there's some more. There was another question I saw, but I'll ask you a question also, Bono. Um, when we there's some, like for example in maple syrup urine disease, it's quite obvious, right? From the very beginning, you can already see the symptomatology. But how about these other two and other rare diseases, no, where the symptoms are vague or they can be come out later in life, no? I think this is a difficult question, but when should we start thinking about rare disease? So hindi naman umabot ng 8 years, no? Parang ano ba yung, what is the main question that you ask yourself to start thinking about we are not dealing with a common thing?
Ma'am, thank you for that question. It's a very difficult question to
It's a
answer.
difficult one, but that's the
Yeah,
one that we have to ask ourselves, right?
yes,
Yeah.
ma'am. So I think it is important that even at the onset, even when presented with a common condition, it should be at the back of our minds to consider these conditions. And there should be a frequent evaluation. It should be frequently asked, no? Is this the correct diagnosis? Every time we assess our patient, we have to think of that, I think. Now, especially for our cases, as you have seen, like for example, MSUD, they can present similar to, they can actually have sepsis actually
Right.
still, no? But on top of that, if there are things that will not fit, like for example, you've been giving antibiotics, but you noted
No
the
improvement.
the CBC improves, the blood CS is okay, but why is the patient still looking that way?
Yeah.
No, so we have to have a frequent evaluation and think of other causes. Like as you can see, these zebras are present. No?
Yeah.
So So we think of horses, zebras are present, and we see that now, no? And especially in PGH, ma'am, so we see that more frequently. So I think that is something that we should think of always.
Yeah, one of our participants, Jan Songkuya, was saying that he has a son who was born in the Philippines but was diagnosed with IOPD while vacationing in Singapore. Okay. So, yeah. So I think, okay. And then there's another question here. Question ko po, meron po bang test ng rare diseases o ibang rare na, na mabilis bukod sa confirmatory test po sa newborn screening? Are there some other tests that can be done? I think that's the question.
Okay. So, ma'am, for the patients, because there are 7,000 rare diseases, and
Yeah.
the manifestations and even the testing will be different from all. Uh, Although majority are genetic, so one testing, especially for a couple who wishes to know their status, especially if there are risks in the family, so they can do carrier screening. I think that that would help, no? But then again, this testing is still limited, no? It will only detect for a number of rare diseases, genetic rare diseases, no? So there are tests like that, ma'am, no? Yung mga genetic panel,
Yun.
which tests for conditions, no? Genetic conditions.
Yeah,
May
okay. So,
question ako. Oh,
sige,
sige,
go
sige.
ahead, Stel. Tapos last
Oh,
na tayo kasi
oo nga.
tininan ko na kung malapit na tayo
Overtime
Go
na
ahead, Stel.
tayo.
Go ahead.
Hindi, ang question ko lang, Bon, kasi di ba yung newborn screening, yun yung project yan ni Ma'am Menchit Padilla. Diyan siya naging naging what do you call this, most outstanding no. Napadala pa nga siya sa sa
Opo.
ah, oo, abroad and all that. So, my question is, how does it fit in? Kasi yung sa newborn screening, parang ang nakikita ko palaging pasado yung patient, pero hindi yata nasi-screen talaga yung mga ganito.
Opo. Actually, parang misconception nga po yun na parang, oh, na-newborn screening naman, bakit may ganitong
Oo, yan.
So actually it should be ano din, no, communicated with the families or to everyone. The newborn screening is limited to just 29 disorders. So it does not screen for other
Everything. Yeah.
conditions and rare
So,
diseases.
nakakalusot
So,
talaga yung iba. Hindi,
opo,
hindi
hindi
nasi-screen.
po talaga. Oh,
Oh,
hindi po talaga lahat, no.
okay.
29 lang po. Eh meron po tayong mga actually more than 10,000 na rare diseases na. Tapos hindi naman lahat 'yon ay genetic. Ang isa pang problem, Doc Susie, Doc Stella, is merong mga rare diseases na undiagnosed pa, no? Meron pa
Yeah.
mga gano'n na hindi pa natin
Yeah.
alam. So kaya po may
Yes.
nadi-discover pa din every year. So another set of problem 'yon kasi rare na nga sila tapos undiagnosed pa, wala pang treatment, wala pang diagnosis. So ang kaya po kung mapapansin niyo dun sa mga na-present kanina, marami doon supportive ang care. Kasi wala tayong mabigay na ano, no? Symptomatic lang mainly po yung pwede nating mabigay.
Yeah, but I'm hopeful, Bon, with all the work you and Menchit are doing and the rest of the institute,
Yeah.
na we will continue to improve still, no? Parang ano
Oh,
naman tayo we're moving forward, we're learning more, and malaking serbisyo na nabibigay na talaga. So
yes.
thanks a lot, Bon. This has been a wonderful conversation and presentation. I'm gonna go back and listen to it again. And I think there is always so much we have to learn about how to help our patients. So we are going to do so. Thank you so much, Bon. And are we going to our next speaker? To our next week. O sige, wag muna. So muna, we have our evaluation poll results, and you can see that. We'd like to ask you to uh, fill up fill up the panel discussion poll. So panelists demonstrated thorough knowledge of the topic. The panelists were well prepared and organized. Panelists spoke clearly and audibly, and the panelists used appropriate language with technical medical jargons adequately explained. So thank you so much, Omer Paisa. Contributed to new perspectives and knowledge on managing various health issues. So thank you for participating in the poll kasi this helps us and helps the speakers, but I can see that you're all You're all answering in a favorable way, and thank you, Bon. You've been very, very effective. So next week, okay, don't miss this. This is very interesting. Next week, we will have former Health Secretary Pauline Jean Rosel Ubial. And Pau, after serving as Secretary of Health, moved on to dedicate her public health work to tuberculosis. Now, the interesting thing is, she's saying, when we had our conversation still, no, she was saying that so many of the cases, we are one of the leading, this is not good to say, no, but one of the countries with very high TB burden. And that's not a good thing because we can treat it, we can diagnose it, but somehow we're not getting our act together. She was saying that a lot of patients with TB are actually asymptomatic. And I was actually looking at the contagiousness, no, they are not of TB, is about 4 in our country. For every person who has tuberculosis, 4 will be infected. In countries where you have good control, less than 1 yan eh. For 1 person with TB, baka walang mahawa, no? Pero sa atin, for everyone, 4 are get infected, and there's a lot of antimicrobial resistance. Now, one of the things that they're doing now is that they are doing prophylactic treatment. So if somebody in the family has TB, they already give medication to the household.
Yeah.
No, di ba, Stel, yun ang sabi niya, no?
Oo.
Prophylaxis na.
Yeah.
And she talked about no, yung mga health workers na nagkakaroon ng TB. No,
Yeah.
so these are things we need to be aware of, learn more of. But she was also saying the good news is we're using artificial intelligence to do mass screening of tuberculosis. So X-ray, no, yung mga X-ray, binabasa through AI. A screening, no, hindi pa to diagnostic, syempre titingnan ng radiologist. Pero this is one of the innovations, and I think this is going to be a great discussion for everybody because we should all pitch in, be involved and do something about tuberculosis. Very embarrassing. We have one of the highest rates in the world. So before we end, we have our health updates webinars archived at the TVUP YouTube channel for your convenience. So just go to the TVUP YouTube channel. Actually, if you go to the TVUP YouTube channel, there's so many other topics aside from health, no? But I would like very much to encourage you to go back and see topics that you find interesting because we really have great speakers. And then for those of you who are very busy, we have some selected presentations that are featured in snippets. So we have what we call the TVUP shorts. So you can watch them at your convention, at your convenience at the TVUP channel also. So this formally closes our webinar for this week. We look forward to your company again next Friday. So it's
Together,
late.
yes. Together, let us keep updated on health and medicine.
Okay, so keep safe, stay healthy, and see you online.